Hello and welcome to our webinar series, Candid Conversations on Health. Throughout the year, we will tackle a variety of topics related to our health and wellness. The focus of today's webinar is Minority Mental Health Awareness Month. This webinar is being done in collaboration between LDH's Bureau of Community Partnerships and Health Equity and the Office of Behavioral Health. My name is Ayana Usuri, and I am the support coordinator for the Louisiana Department of Health's Bureau of Community Partnerships and Health Equity. The Bureau of Community Partnerships and Health Equity is devoted to increasing the citizens of Louisiana's knowledge about what affects our health, especially for those in particularly vulnerable communities and populations. This devotion is rooted in raising awareness through webinars like today's, and partnering with stakeholders in the community to move forward toward a healthier Louisiana. At this time, it is my honor to introduce Jaquila Dockery, Louisiana Department of Health Office of Behavioral Health student intern, who will share a few welcoming words. Ms. Dockery.
Thank you for that, Ayana. Hello and welcome everyone. I am Jaquila Dockery and I'm a current MPH student at Tulane University. I have the pleasure of being one of the LDH summer interns, and I was assigned to the Office of Behavioral Health. Today, I have the amazing task of welcoming each of you to our Candid Conversations webinar covering the topic of minority mental health. July is Minority Mental Health Awareness Month, so now is the perfect time to engage with our viewers and provide some important information on this topic. During this webinar, our participants will discuss what mental health is and how it affects various minority populations. Each year, the United States grows as a more diverse population, ultimately creating more minorities. Additionally, racial, ethnic, sexual, and gender minorities often suffer from poor mental health outcomes. These factors include, but are not limited to, inaccessibility of high-quality mental health care services, cultural stigma surrounding mental health care, discrimination, and overall lack of awareness about mental health. Today, we hope to bring some awareness to the issues this group may experience as a whole, as well as ways to assist with ways to, experience behavioral health related issues and/or concerns. Again, I welcome each of you to today's webinar, and I hope that you do take some notes to bring awareness to this issue, and thank you.
Thank you, Ms. Dockery. Before we get started, I thought it would be fun to do a brief activity. I encourage everyone who's here to participate in this breathing exercise. Research shows that just 30 seconds of deep breathing can reduce stress and anxiety levels. So let's get started. Follow the instructions on the screen to participate. Okay, wonderful. I hope that brief exercise brought a little peace to your day. Whenever you feel like you need to catch your breath, doing an exercise like this from Calm or another resource can provide instant relaxation. Thank you so much for participating. Now I'll provide a brief outline of today's event as well as introduce our facts about minority mental health. All right, so we're starting right now with our intro and welcome. Then I will go over the facts related to minority mental health. As I've mentioned, we'll have our panel discussion, and then we'll go over those key takeaways, those facts again. All right, so as far as the 4 facts for minority mental health, the objective of this webinar is to increase awareness of aspects that affect our mental health daily, to discuss healthy mechanisms to cope with mental health challenges, as well as how to break down the stigma associated with mental health. So first, mental health challenges can affect anyone regardless of race, gender, or socioeconomic class. However, minority communities can face additional challenges when attempting to access mental health care. Next, Mental health can affect our emotional, physical, psychological, and social well-being. It can influence how we think, feel, and act, as well as help determine how we handle stress, relate to others, and make healthy choices. Number 3, examining our mental health is important at every stage of life, from childhood and adolescence throughout adulthood. So when seeking assistance with mental health services or with mental health challenges, find healthy outlets and/or trained and compassionate individuals who are willing to offer support, whether it be during hurricane season, the seemingly never-ending COVID-19 pandemic, experiences of racism, or any emotional crisis. And last but not least, mental health is an important part of our overall health and well-being. So these 4 facts are ones that you will hear throughout the webinar tonight. I want to stress the importance of getting information from trustworthy sources. So if you are going to share mental health information with loved ones or within your communities, please only use information coming from websites like the Louisiana Department of Health, the CDC, and the like. We will provide you with a 1-pager via email after this session to aid you in how to share mental health information. Sharing accurate information can help save lives. And now it's my pleasure to introduce the Deputy Director of the Bureau of Community Partnerships and Health Equity, Mia Orr-White.
Thank you, Ms. Usri, and thank you all for joining our Candid Conversations on Health National Minority Health Awareness Month webinar. First, I want to thank each and every one of you for joining today's conversation. Pardon me, having issues with my Zoom. Aha, there we go. Thanks everyone for joining. I really hope that you find today's discussion informative and helpful. Before I turn the session over to our moderator, I wanted to provide you with some helpful information for people with Medicaid insurance. If your medical insurance coverage is from Medicaid, then you must make sure that your information is up to date. This includes your address. If you do not update your information, you may miss important letters from Medicaid, and you could lose your health insurance coverage. To update your information, please visit the self-service portal at www.ldh.la.gov/mymedicaid, or you can call 1-888-342-6207. So without further ado, today's moderator is Dr. Shanoya Bryant. Shanoya Bryant is an assistant professor at Xavier University in the Department of Sociology, where she leads the Health, Medicine, and Society concentration. She possesses a doctorate in medical sociology, a master's in sociology, and a master's in public health and international healthcare organization and policy, with a concentration in maternal and child health. Whew, that was a mouthful. Prior to committing to her position at Xavier, she was in the process of obtaining her Master of Art degree in art history. So this is a very talented lady. Her research specifically examines how the representation of women of color, in media impacts their mental health outcomes. Her interests are many and include race, gender, identity and health, as well as health disparities and social determinants of health in minority populations. One of Dr. Bryant's greatest passions is being an educator at the community level and in the academic setting. She feels the classroom is a place to use education as resistance, as a means to disrupt systems of injustice, to shift the collective gaze, reclaim narratives and histories, and most importantly, as a place to foster cultural exchange as a means to freedom, self-liberation, and joy. All right, and with that, let's get ready to have a great discussion today. I'm excited about it. Take it away, Dr. Bryant.
Awesome. Thank you so much, Dr. White. I really appreciate your introduction. So thank you, Mrs. Dockery, Mrs. White, and Ms. Usri for starting today's event for us. For each of you, community members and stakeholders who have taken the time out of your very busy schedules to attend this important discussion, we want to thank you so very much. In this webinar, our hope is that what you hear, you will find useful, empowering, and encouraging. We want you, the audience, to leave this conversation empowered with the knowledge to understand various aspects of mental health. We have trusted gatekeepers from around the state who will lead and be a part of this discussion. So before we go any further, let me do a brief introduction of our panelists. Brian L. Turner is PhD, is a native of New Orleans, Louisiana, and completed his undergraduate studies at the Southern University at Baton Rouge. He completed his doctoral studies in clinical psychology at Jackson State University. Dr. Turner currently serves as a licensed clinical psychologist in private practice, Moments of Truth LLC, a tenured associate professor in the Department of Psychology at Xavier University of Louisiana. And he serves as the director of the African American Diaspora Studies program at Xavier University of Louisiana, my apologies. Dr. Turner's work as a professor and clinician is grounded in his multicultural training, which examines the impact of culture on mental health. During his time at Xavier of Louisiana, his research has focused on Black male experiences in higher education, Black women and risky behaviors, and mental health and HBCUs. Dr. Turner is the proud father of the intelligent and beautiful Blair Layla. He is also the daddy to Von Duke Von Duke Bailey Turner, a full-blooded German Rottweiler. That is the cutest. Dr. Turner previously served as a board member for the National Alliance for Mental Illness, Louisiana, and Encore Academy Charter School. He currently serves on the board for the Tremay Education Program. Our next panelist is William Sandino, and he's a licensed professional counselor in the state of Louisiana. He received his MA in mental health counseling from the University of Holy Cross and has a BS in behavioral science and criminal justice from Midwestern State University. William's parents both immigrated from Nicaragua and is a first-generation born American. He uses culture, education, equality, empowerment, and self-exploration to help clients identify their strengths and to promote active change. His professional interests and expertise include addiction recovery, social justice, racism and discrimination, first-generational college students, queer LGBTQ+ identity, and trauma related to emotional, physical, and sexual abuse. Our third panelist is Chastity A. Butler. She is a licensed professional counselor supervisor with over 15 years experience in mental health rehabilitation and counseling. Born and raised in Tallulah, Louisiana, Ms. Butler is a lifelong resident of Northeast Louisiana and owner of C.A. Butler Counseling and Consulting LLC and the Butler Project, a nonprofit with a mission to combat homelessness and assist those at risk of becoming professional and community, at risk of becoming homeless and with mental health abuse issues. Ms. Butler is a member of several local and state professional and community organizations, including the Louisiana Association of Counselors, Alpha Kappa Alpha and Sorority Incorporated, former member of Junior League of Monroe, as well as several local boards. Ms. Butler has a passion for advocating for the rights of the underserved, as well as increasing the awareness and reducing the stigma of mental health issues in the African American community. Our last panelist, Ashley Jefferson, Dr. Ashley Jefferson is currently the senior advisor to the assistant secretary in the Office of Behavioral Health. Dr. Jefferson has been with the department since 2013 and has served in both clinical and executive administrative capacities as a psychologist and now the senior advisor, formerly termed Chief of Staff. Dr. Jefferson is a native of South Louisiana. She graduated from Louisiana State University in Baton Rouge. She furthered her matriculation and obtained her Master of Arts and Doctor of Psychology degrees from the Texas School of Professional Psychology, formerly Argosy University in Dallas, Texas. She has clinical experience with all ages, most of her work with marginalized and disenfranchised populations. In 2020, she was accepted into and successfully completed the National Council for Behavioral Health's Addressing Health Disparities Leadership Program. A core focus of this program is also community engagement and improvement. She also serves as the OBH Health Equity Action Team co-chair and ambassador for the LDH Health Equity Initiative and is actively involved in the OBH communications, legislation, policy development, and engagement efforts and relations. These are our panelists. They are going to help us have a brief but deeper discussion. As we start this panel discussion, it is important that we continue to remain vigilant in the fight toward pursuing a healthier Louisiana. It's important to note that this discussion will be factual, based in science and understanding. Let me be the first to say, as the moderator of this session, that people have a right to feel what they feel regarding their past and their present experiences of racism, sexism, mistreatment, or injustice. We know these experiences play a part in people, populations, and communities' trust in healthcare systems. So let's get this panel discussion started. So my first question for our panel, and any of the panelists who want to chime in first can take it, but what is your profession and how is it related to mental health?
All right, I'll go ahead and jump off the porch. Good evening, everyone. Thank you, Ayana and team, Louisiana Department of Health, for bringing us together at this time. The very serious topic, but one that we should consistently have. I am Dr. Turner, and as it was stated, I am a licensed clinical psychologist. I've been licensed in Louisiana for almost 8 years. I was previously licensed in Florida where I practice, and I'm also a professor at Xavier. The reason why I think I'm here is because I have a two-pronged kind of role. One, I train students and prepare them for graduate study, as well as work with a strong background in psychology as an undergrad. And then I'm actually practicing and using the training to assist people who experience psychological distress. And so what I hope to bring to the table on this evening is a conversation or some thoughts around what can be done as well as what's happening. So that's why I think I'm here.
Okay, I'll go next. I am Ashley Jefferson. As was mentioned earlier, I have a doctorate in clinical psychology, but my role here at the Louisiana Department of Health Office of Behavioral Health is a little different from my fellow clinicians on the panel with me. While I've done clinical work, this is a little bit different in that it is more indirect service and more about programming, consultation, and policy development to help the citizens of Louisiana. So we do a lot of those kinds of things. So it's a little different, but all of the information that we utilize and that we use, it is fact-based, of course, and it's evidence-based, and we use it to help better the healthcare and behavioral health services in the state for our neighbors here.
Okay, sorry, I was muted. But I'm Chastity Butler, and I am a licensed professional counselor supervisor. Have been licensed in the state of Louisiana for over 10 years now. My background is working with the underserved, those who are not readily available or readily able to access mental health care. We remove all the barriers. We go into the homes, we go into the schools, we go into their environment of least restriction. So my passion is actually making aware those who are not really aware of or how mental health affects their daily life.
And Dr. Sandino, would you like to share?
My name is William Sandino. I'm a licensed professional counselor here at Mandeville. I have my private practice. And on a day-to-day basis, I'm constantly having a variety of, serving a variety of mental health needs. I'm Hispanic, so I tend to get more of the problems and some of the issues that arise from that community, and trying to really give them a voice and be an advocate to some of the problems that arise with that and deal with that on a daily basis. So thank you for having me.
All right, so my next question is, and it's going directly to Dr. Turner, is how would you define minorities beyond the idea or the concept of ethnicity? I think you're still muted.
I'm getting back used to being in person, so I'm getting out of practice. So my apologies. Thanks for reminding me. It's an interesting question. The program I attended at Jackson State specifically looked to marry the ideal of culture and mental health and the practice of psychology. And so early on in my training, the ideal was that we don't necessarily need to leave out culture, right? And culture broadly defined, inclusive of age, gender, sexual identity, sexual orientation, race, ethnicity, nationality, religious, spiritual beliefs, able body, abilities, as well as intellectual abilities in that respect. So one of the thoughts that I have to that question is very simply, we have to include culture in terms of how we think about people, regardless if it's a person of color, if it's a person that's white. Our cultural reference actually shapes a lot of how we deal with stress, how we deal with mental health, and how we deal with our everyday experiences. My dissertation looked at how persons deal with stress, and the greatest finding was that our culture actually teaches us how we deal with stress. And so what I think about is that we shouldn't be thinking about necessarily anything different, but we should be broadly okay with people sharing their cultural reference and how it helps them deal with things. So I know in New Orleans, people, when I've lived around the country, people didn't know how to handle that, how we do second lines. And I would explain to them the idea that our religious spiritual practice were to celebrate life. And while other people hurriedly would want to bury folks and usher them into the next realm, we celebrate life. So that was our way. And I use it as an example of how culture and race and ethnicity should be included in how we look at mental health. And that should give us another rung on the ladder to assist people with dealing with psychological stress. That was my thought.
Did any of our other panelists want to chime in on that question in terms of how we might view minorities or define minorities outside of the concept of ethnicity? Sorry.
I think that the way that in practice, and let me say this, I'm an active and practicing LPC. So now, I see clients as well as I'm on the administrative side and the business owner side. So I'm kind of trying to marry all of those hats that I wear. But like he was saying, you have to take into consideration everything that comes along with that person, that culture. And now when we are assessing clients for services, we try to encompass and utilize everything that client, their background. We ask them a myriad of questions, and they often want to know, well, why do you want to know this? Why do you want to know that? And we try to simplify it and tell them that all of these questions that we're asking is to help us to get to know you as an individual better. And once we understand you as a person, we can't take a cookie cutter approach to treatment. So all of the questions that talks about, your spiritual beliefs, your background growing up, what did you do growing up? How were you disciplined? All of those things, kind of gives us a flashlight into what that person, how that person was brought up, and how it's going to be best to treat them as an individual.
So then my next question would be, what do you all see as the major barriers for minority communities getting adequate mental health care? So I know we've talked a lot about being culturally sensitive, things being culturally informed, but how do we see these things maybe causing some barriers in cases, right? Because we've also heard culture causing barriers, but also culture helping to facilitate progress. So what are some barriers that you all have seen that might help impede people getting the help that they need, minorities specifically?
One barrier in particular is the stigma that's attached, that has historically been attached to mental health care, mental health illness, how people view what mental health illness is. So just the stigma attached. And that's one of the things that I try to make people aware anywhere I can, even in regular everyday conversation, just to make people aware of what mental health is and what mental health is not, what mental health illness is and what it is not. Because too many times people have equated mental illness with being crazy or a sign of weakness. And we know that that's not the case, but other people, lay folks, they don't know that. So we try to liken mental illness with physical illness. How would you treat physical illness? Well, mental illness the same way. It's treatable, and we have to just take some of that stigma away.
And to piggyback on that too, But speaking of stigma, right, there are these studies out there that talk about how pervasive stigma is, how it is such a, not only a barrier, but a huge impediment to just even seeking out and educating yourself about what mental health is, which is a big reason why people are not aware and why they don't know a lot about mental health and mental health issues, right? So I think there was this number, something like about 75% or 3/4 of Americans still say that they aren't content with the way that the state of mental health in the United States, right? And surprisingly enough, 84% of those people are actually people who are living with mental illness or mental health conditions, which is, these are staggering numbers, right? Because we're talking about helping people and building communities and erasing stigma and stopping these negative thoughts that are happening about it so that we can get to the core of treating these things. But the overwhelming majority of people who are living with these types of conditions don't feel comfortable enough to seek out treatment. And that in itself is a barrier, in my opinion.
I'm going to go a little different route, and I will say that the biggest barrier is actually a system that does not seek to treat persons of color and minority communities, immigrant communities, as persons who actually have these disorders. So when we look at how law enforcement, when we look at how healthcare systems actually serve to actually stigmatize people of color and minority communities with mental health, right? So what that means is our training programs don't train clinicians to actually think about the role that culture plays. And they actually, in some ways, embed systemic racism and institutional racism in the clinicians. Mm-hmm. We look at how even in accessing healthcare, mental health care, even deeper, you don't have clinicians who even want to see folks who are culturally different in many ways, right? And so we oftentimes talk about the barrier, not the barrier, but the burden that clinicians of color and clinicians who do the work in minority communities, the immigrant communities, actually struggle with, because one, persons oftentimes don't have the resources to pay for services that they need. Persons oftentimes don't even know how to access the services. So just as Ms. Butler alluded to, the historical way of delivering services is not to go into people's homes, was not to go to school, because there was just certain privacy and confidentiality matters, right? So we're now having to even reorient the paradigm by which we deliver services. So to me, the biggest barrier is the fact that we still have a racist system that does not look to provide services to people of color or persons who are outside mainstream white America.
Interesting.
And that really got at the next question I was going to ask, like what were some of the lesser known barriers or less obvious barriers that we might consider? So I'll go into another question, because we talked about the barriers, but then there is also literature that cites that, you know, because of communities of color having a collective nature about themselves, there might also be some advantages. So what advantages do you all feel minority community members have with respect to mental health, and how can we maximize those benefits?
I think the benefit to kind of play with her point is that oftentimes within homogenous communities, what happens is people actually are able to identify and share resources that are actually helpful, right? I oftentimes think about it in New Orleans post-Katrina and even post-Ida recently. It was very easy when people found a good contract, when people found resources, to share that with their neighbors. And it's the same for mental health care, right? In my private practice, which by being a full-time professor, I take very few, I won't say very few, but I take a limited number of clients. Oftentimes I'm overwhelmed with the number of people who are willing to wait for services. And so I've tried to start to catalog a referral network so that if I'm a little bit heavy, I might find somebody for someone else to go to. And so I think the reality is that oftentimes community of color immigrant communities have had to make it work. And what happens is in those enclaves, in those communities, people find out who they can trust. And so I think that's one of the things. And honestly, even in thinking about some of the smaller barriers, I think about little things like growing up and people talking about you get a crazy check. And people understood, you know, even then how to play the system to get resources, right? It was ulterior motives. But, you know, if you're living in a poverty-stricken area and you can get financial means, then and it's the same thing. And so I think sometimes once again, the system stigmatizes folks for realizing how to play the system. But once again, I think folks are able to find that within their community, they can share resources, they can identify resources that are helpful. And I think that's a huge thing about within communities of color, immigrant communities, folks are able to share those resources because people will tell you, look, don't go see Dr. So-and-so because they're not going to treat you right. Or don't go see this person because they're just going to give you a pill and get you out of there so they get paid. So I think it's very, very nice that communities are very caring and the homogenous communities take time to actually identify resources that they can share and that are helpful.
And to add to that, if I could, I think too, another benefit of having that type of society is the empowerment that comes with that, right? So there's that responsibility, there's an empowerment, and then there's this, we can stick together. And a big piece of making it over any adversity is having support and connectedness and those types of things. So I do think that added piece of responsibility that comes when you are part of a group, knowing that you care for each other and you take care of each other, does help to add a benefit when you are talking about caring for yourself and caring for those in your community.
All right, so this question I would like Dr. Sandino to address if possible, because we have talked a lot about stigma and we just talked about kind of the collective responsibility and accountability that we can take to help each other. But in some instances, we might have people who are isolated, right? They don't have access to someone who's willing to say, hey, don't go to this doctor because they're not going to treat you right, or hey, don't go over there because they're not going to give you the resources you need. So how would you suggest someone disassociate themselves from stigma to seek help when they're in an environment where they're isolated and they don't have support?
That's a good question. I think, part of the journey is when we decide that we want to find some help, we decide at some point that there has to be a better way. Stepping away from our own stigmas at that point is the first step. As we all know, changes come from taking that first step, those small steps. Those changes invokes bigger shifts in the very stigma that we're having a conversation about today, about changing. And it takes that individual, it takes that person to invoke that change so that then that ripple effect takes in that immediate circle of influence of that person. And that's the beginning. That's the beginning of taking ownership and really going forward with that change and quieting some of those stigmas, that personal and public stigmas.
Talked about isolation, Dr. Bryant. You talked about isolation, and I have just personally begun to think of that differently. The pandemic, it shut everything down they didn't ask me, they didn't ask you, everything that just shut down. And we had to scramble to find different ways of doing things, not just professionals, but, folks from everyday life. With the rise of social media, really nothing is isolated if you look at it in a different way. People now who would never have walked into a doctor's office or a psychiatrist's office or a mental health agency have reached out because, with the rise of telehealth, you don't have to leave your house in order to speak to a qualified professional. You don't have to leave your home in order to get, your prescription meds. You don't have to leave your home in order to have your meds delivered to you. So isolation is really not really isolation anymore if you look at it differently. So we've been able to reach a lot of people who, like I said, never would have walked into an agency just because of the rise of telehealth and even social media, I would say. Different groups and things of that nature.
Thank you for adding that. What I would add to that is that then it brings another conversation, right? Because specifically we talk about minorities, and we also have to have a conversation of internet whether they have that or not, bandwidth
Right.
and things of that nature. These are real discussions that we need to make and have, I should say, and not ignore the fact that, not everybody has that, right? And so
True.
what do we do about that? So I love this. I love this open panel to have that kind of conversation and educate.
Right. And Mr. Sandino, that was a question as well, what you talked about. A lot of people who are in like rural areas and things of that nature, they may or may not have had access to Wi-Fi. So with the different insurances, even with Medicaid, they open the doors to just having a phone conversation. I may not see you, but I can identify who you are, and I can identify myself, via audio. So that was a barrier that we had to overcome because not everybody had access to Wi-Fi, but many people did have access to a phone. So it's evolving slowly, but it's still a good thing. It's evolving.
Yes.
So in considering, I think the domino effect or the ripple effect that Dr. Sandino mentioned, I don't think we can ignore the fact that there have been historical, right, social, political forces that have been the driving mechanisms of the stigma, of the barriers, et cetera. And so what do you all feel is the historical, but also the current impact of racism on mental health in the Black community and communities of color?
Go ahead.
No, you got it, Ms. Butler. Go ahead. You good.
Well, I was just going to say, historically, the way that mental health was looked at by police and even doctors in emergency rooms, they had a tendency to criminalize the behaviors that they saw rather than look at those as symptoms of a bigger issue or a mental health issue. They criminalized it and threw people in jail rather than refer them to treatment centers or to doctors. And then sometimes those same doctors that if they did have access to medical care, those doctors would not historically take those symptoms seriously. They tended to maybe throw a pill at them, but not get to the deeper issues. So hopefully, now with more awareness, us having this conversation, things will start to change. I have seen some, limited progress in that, and hope to see more in the future. And not have those behaviors criminalized. If someone is behaving erratically or in a way that they're not used to, not to call the police right away. Or if they do call the police, educate the police on those signs as well, and not to, immediately reach for their gun.
So I'm going to play with a little historical kind of thing. The diagnosis of drapetomania was formulated by psychologists post-slavery or kind of after slavery as a diagnosis to give formerly enslaved or enslaved individuals who were looking to escape slavery. And drapetomania was defined as persons who wanted to leave slavery and would talk back, would destroy property, and would act out because they no longer wanted to be enslaved. That's the example of that system I was referring to that used psychology. And I am ashamed that as a psychologist, they did this. I wasn't there back then, but when I think about it, that's an example of what racism in these systems will do and continues to do, because that becomes the origins of why clinicians and other institutions and other agencies will not look at persons of color, immigrant communities as humans. And so what happens is racism helps to other or dehumanize people so that we can treat them in ways that we would never do to anybody that we cared for. So yes, those police officers who claimed that Michael Brown was enraged and he looked like an animal, right? For George Zimmerman to assume that a boy, a kid, was a threat and to hunt him down and kill him. For us to see Sandra Bland, once again, put into a jail cell and left there to die. When we talk about Alton Sterling, you know, the list goes on. And then, of course, when we think about immigrants due to language barriers and police officers not being able to communicate with them. And so now the language becomes a mental health issue, right? So very simply put, what I think about is the fact that, once again, we have to create a system of training. We have to create educational systems that provide clinicians with the training to work broadly across the board with anybody. That's why it's so good to be able to sit here with such a diverse group of individuals, right? Who cross gender, who cross racial, ethnic groups, who cross training paradigms, that we can talk about the fact that we're all here to help, but the reality of it is that racism still serves the system to treat people as others. And so that's why I think when we talk about the group, the Louisiana Department of Health, it becomes so important that we can actually look at the fact that we find that we are able to provide services to individuals and communities that would not historically get those. And so I think that we have to be mindful that racism isn't something that we actually, and I'm be sensitive to what Sister Butler said, that we might can fix. I may not be as hopeful about this, and that might be because I'm getting to the point where I just call things as I see them. When I sit in meetings and on committees, I just find that I just have to be honest that until I start to see clinicians who are white, clinicians who are cisgender, clinicians who are heteronormative actually want to work across their privileged positions, right? It's easy for a person of Spanish-speaking background to understand why they need to work within their communities. It's easy for a Black male to understand it, easy for a Black woman, but we have to get our white colleagues on board. We have to move the needle. And so I actually sometimes get sad, but what I'm gonna do is I call myself to the table to be loud, to be an advocate, and to speak to those issues, because we can't continue to be silent. I think sometimes in a playful way, when I heard you all talking about being silent and isolated, I think about that professionally oftentimes, right? Is that if we're in our own offices and we just work to see our clients, we get caught up with just our everyday run-of-the-mill stuff. But what we miss is that when we're in a communication or in a group with others, that kind of energy is invigorated once again. And so I'm reminded as I sit here that we also as a community have to connect and support each other and inform each other about what's going on, and to bring folks to campus at Xavier, which I try to do. I try to bring in medical psychologists and IO psychologists and different psychologists to have the conversation. But at some point in time, I have to pull us to the
I think you're on mute.
Oh, you're muted, doctor.
I did. I got it now.
Okay.
I was. We got questions, and I'm trying to read the questions too. I'm trying to do too many things, and so I think that's what we have to make sure that we do that. I'm also aware that I think our moderator. So Ayana, you jumping in? Okay, yeah. So I didn't want to. I was wondering. Okay, so yeah, I'm gonna read the questions. Okay, none of the questions are for me.
Before you do that, can I add on a little bit to what you were just saying? Dr. Okay, so
I'm not running it. Yeah, go ahead.
No. I just didn't want, sorry. No, but I wanted to make sure that I went back to that piece that I talked about a little bit earlier about responsibility, right? Collectively, we have a responsibility culturally, right? But in our own subsects, like you were saying, we do have a responsibility also. And I just said this to, I think it was the Governor's Fellows the other day when we had a discussion that it's unfair a lot of times, but to whom much is given, much is required, right? And those of us, there are those of us who do understand that this still exists, that racism is here. And sometimes just something there, well, of course, there is no one fix for it all, right? But sometimes just the knowledge of knowing that you can acknowledge that this still does exist, because there's still so many people out there who still deny it, right? And that is an added trauma to people who experience this, who live this, who have to deal with this daily and cannot escape it. So that piece about that responsibility is what I wanted to add.
And just to be playful, I think that's a part of the system as we sit here, which oftentimes I think we find ourselves preaching to the choir, right? I'm pretty sure that our colleagues and those closest to us know how we feel and that kind of thing. And so yeah, I think when you're sitting in your position to speak, not just to us, but to turn around and preach to the pews, you know, that the governor and elected officials, which that's one of my kind of practices. I love when I can sit in a room with elected officials and just know on them and showing them about how they're not doing what they're supposed to do. And that, if you can give millions and millions of dollars to a company coming in to build something, it doesn't take a whole lot per se to start to fix or address some of these concerns. So I agree 1,000% that we got to start calling them to the table. And once again, when we look at our professional organizations from our APA and ABSI and LPA and ACA, we got to start to really make sure that legislative initiatives are part of what we do and that we take those home with us.
Okay, great. This has been a wonderful conversation. Yes, Dr. Bryant, I don't know, she may have had some internet challenges. Hopefully we can get her back on, but I'll do my part to try to move the conversation along. But this has been wonderful so far. But I'll go ahead and shift gears here. So Ms. Butler, I'm going to come to you with the question. So our physical and mental health are closely linked. Those of us who have long-term physical health conditions are also likely to experience mental health issues. So can you explain for us, what does long-term or chronic physical conditions mean?
Okay, sure. I'm not a medical doctor, but there's vast, medical research that, documents the correlation between physical and mental health. But to answer your question specifically, a chronic physical health condition is simply or broadly defined as any condition that lasts a year or more and requires treatment, ongoing treatment. So it broadly, that's what it is. A chronic condition is just something that you will have to manage over time. It's not something like, you take a round of penicillin and you're cured. A chronic condition is something that you have to ongoingly manage.
Okay, that makes sense. Thank you for that. So I'll move to Dr. Jefferson then with a follow-up regarding that. So why are people with chronic conditions at a higher risk of developing mental health disorders? And if anyone else would like to chime in afterwards, please feel free.
Yeah, so kind of goes back to what I was saying a couple of questions ago about compounding traumas, compounding traumatic experiences, negative language and negative definitions and stigmatized thoughts and ideals about certain things. So if you think about it, in a sense, chronic conditions, things like cancer, things like sickle cell disorder that do in many areas, and for sickle cell disproportionately affects people of color, especially African-American people. These types of illnesses can, in a lot of people, bring about a sense of helplessness, right? Because these are things that you have no control over. These are things that you did nothing to get, right? And yet it can feel like it can be punishing or something like that. And just put on top of it that you are a person of color who is experiencing daily the injustices and the issues that come along with being someone who is a person of color. These things can take a toll on your mental health. So your physical health is already weakened or in a state that is not optimal. And along with that comes the mental toll of having to cope with those things. So if you don't have a support system, or if you don't have the necessary skills that you might need to get through those things, it can make it much harder, and it could lend one to greater risk of developing a mental health condition.
Thank you for that. I don't know if anyone else on the panel would like to add any more to that answer. All righty. So I'll go ahead and pose one more question to you, Dr. Jefferson, along this topic. What are some signs of mental health issues to look for in friends and or family members who may be experiencing chronic illnesses?
Well, I'm going to ask my panel colleagues to help me out with this one, right? Because I'm going to be very brief with this, because I think everybody has something that they'd like to say. But I would put it into three categories. you can see certain things occurring in one's behavior. You can see something with them emotionally, and sometimes you can even see things physically, right? And it depends on the age of the person, and it also depends on the types of behaviors or the things that you're seeing. So you could see very noticeable mood shifts, one extreme to the next, or a little bit more of some melancholy. And the same thing with physical illnesses. You may see someone getting more headaches. They may start having migraines. They may start having complaining about aches and pains. For children, you may see them, their activity may increase or their food intake may decrease, but these are things that you would have to look out for. But I do think that there are ways to make sure that we're noticing those things and questions to ask if we're ever in those situations. And that's why education is important.
It is, and one sign or symptom that a lot of people, I believe, miscategorize is that extreme anger, that extreme irritation, that explosive anger that seemingly comes from nowhere. That's something that you need to look into. It's not always a behavioral issue that some people like to categorize it. It could be something really going on internally with that person. So if you're, like you said, Dr. Jefferson, if you're noticing differences in sleeping and eating patterns, that lack of motivation and interest in stuff that you used to do, as well as that hair trigger temper, we need to look at that as well. And, those are all warning signs that, that needs attention.
Okay, great.
And to just add one more thing to that, I don't want to be neglectful and leave out the issues about substance use disorder, because when we're talking about changes in behavior and changes in mood, we do have to always think about substance use and substance abuse. And what we've seen, especially time and time again, of course, is in the literature, but if you just go back to the start of the pandemic, we saw a increase in substance use and substance abuse. And so those are things to watch for. Is someone drinking more than they have been drinking? Are they smoking more cigarettes if they are a smoker? If they aren't a smoker, are they smoking? Just taking those things into account.
Right.
Right. And that's actually a perfect segue to the question that I had for you about maladaptive coping mechanisms. So definitely substance abuse and things like that would count as a maladaptive coping mechanism, but are there others that you're aware of that you could possibly share with our audience?
Yeah, there are lots of them, but if it's okay with you, I'd like to talk more about a little more positive about what are the ways that we can help people when they're dealing with certain things like this, because it's easy to kind of see those things that aren't so great about people, but the problem might come in our action, right? Like, how can we act? How can we help people? So in order to be more proactive, communicating, staying connected with people. These are things that we've been preaching since COVID, right? But I do, because I am of this background, this field, repetition begets learning. So let's keep saying it. Sooner or later, somebody will get it. But supporting each other, and supporting each other can look like a whole lot of different things, right? The other ones I have are, making sure that we're safe and that those around us are safe. And sometimes that's as simple as asking, do you feel safe? And this is a very important one for children, because sometimes those very simple questions can open up a conversation and help you to understand what someone is going through. We don't always see it, but especially for our little ones, sometimes their comprehension and the way that they speak and they converse is a little more concrete than those of us who have a little more worldly knowledge, right? And so we have to meet people where they are. Another one is limiting the media intake. Just do your best to not watch as much, because it's a lot of stuff going on, and it can make you feel worse a lot of times. Another one, healthy routines, eating healthy, getting an exercise schedule. That doesn't mean you need to go do 30 minutes of cardio, but something that makes you feel good and that's good for you. if that means sitting out, standing in your yard barefoot and just taking in nature. What works for you to help center yourself those are the things that we want you to do.
Great. I think that's wonderful. Yes, we definitely need healthy, productive ways to deal with the stressors and challenges of our lives. I don't know if any of our other panelists would like to share, but definitely also highlighting what potential maladaptive coping mechanisms can be, just so that folks are aware that, oh, maybe the substance use that I'm doing is in reaction to the stressors that I'm feeling, as opposed to me just having this constant need. I don't know if anyone else on the panel would like to just give a brief list or anything of other maladaptive coping mechanisms.
Well, of course, the use of substances is a maladaptive coping mechanism. But what I've also seen in my practice, and not just in practice, but just from speaking engagements and talking with people, one thing, especially with a lot of men and women, not just substances, but the use of their bodies as a coping mechanism. A lot of people tend to use sex and sexual acts as a means of coping and feeling good. So not if people are thinking, well, I don't smoke crack, I don't snort coke, I don't use meth, and they think that they're good, but they're still doing these other very, very negative and ineffective means of coping with the use of, risky sexual behavior and things of the like. So all of those things, if you're doing any of those things, it could be a sign of a deeper internal issue.
I would say that I think, and I really like the position Dr. Jefferson took, and I think that's actually the more affirming and actually client-centered approach that we should actually have. But I think if we think about the layperson and the concerned families we have,
right?
I would just generally say that I would look out for when people have broad changes from what their normal behavior tended to be, right? So if a person tended to, and we talk about this with depression and anhedonia, right? The loss of desire for pleasurable activities, right? So if you have someone, and if it's a kid that loves to play video games and all of a sudden they're not playing video games, well, some cases that young boy, he may not have discovered girls, and that might be a normal transition. But at the same time, parent may still want to wonder, hey, what's been the big switch? And even at that time, right? Or if it's a student or a person who was formerly very academically oriented and did well, and all of a sudden there are changes in their academic performance or their interest in school. I think that would be my global kind of question. And I try to keep it, like Dr. Jeff said, brief, because I don't want people to go home and think, well, what did all of these say? Just think about it. If there's a major shift in a person's, as Dr. Jeff said, behavioral, mental, or kind of physical kind of stuff, then that would be a cause for concern for me. If you see someone change globally and their approach to life. And then lastly, I think about this one that to me is very important, hope. When you see people and they're struggling, they tend to lose hope, and they start to stop thinking in a future-oriented, in a positive, and a kind of culminating life sort of way. They start to think about the kind of end. And so I would always say be mindful, because one of the things, and we didn't really highlight it here, the growing rate of suicide among Black and Brown teens, and the fact that Black and Brown teens are actually having increases in suicide rate, which once again, the reality of it is that people don't commit suicide because you talk about it. People commit suicide because you don't talk about it. And so making sure that those resources are coming back to the positive, making sure that people know that there are resources. So you have several clinicians here, you have a whole health department here, understanding that there are resources and people, understanding that, yes, church is still a very big buffer for psychological stress, community activities, right? Being physically active and physically fit. There are, huge ways, but the reality of it is that hope thing. And we have to remind ourselves that this stuff is not going away unless, as was stated earlier, we do something about it.
Okay, thank you so much.
My apologies, everyone. It is storming where I am, so my power blinked. Unfortunately, that took my internet out, and it's still out, so I'm operating from my cell phone, so please do forgive me, and my sincerest apologies. Before I ask the closing question, one of the questions that I do have, because I do understand that according to Ms. Usuri, you all have been talking about maladaptive behaviors. And so as a person who may be looking on at someone who you do know used to love a certain something, a certain behavior, and that behavior has now changed, or you see them coping in an unhealthy way, what would you say would be the healthiest and the safest way to approach them about it that wouldn't exacerbate the issue and might actually encourage them and push them toward help and not toward further harmful behaviors?
Well, I would say as simple as right now, make a note for yourself to go in and learn about how you can approach someone, right? Or seek out someone who you know might be able to guide you in that process. But a lot of times it's just as simple as asking a question, and a very simple question, but knowing your intentions from the place that you're coming from, understanding that you can't fix it, but what you are there to do is find out and gather information and possibly help and get them to a next step that can help them. Not to be negative in your approach with it, no judging, just making sure that you're coming with the purest intentions and making sure that you're speaking to people the way that you would want to be spoken to if this were you in that situation. That would be my suggestion.
Yeah, I like that. I think the most important thing, as you mentioned, is really setting that atmosphere to where they feel safe to open up, not judged, or further strengthen some of the stigmas that we were all talking about earlier. Just to feel understood, and just a conversation without judgment, I think is key.
And so for our last question, I just would like each panelist to address, what do you want to be a key takeaway from this conversation today for our audience, for each other, for our communities? What is one key point or a couple of key points that you would like us to walk away with?
I would love for everyone to just be aware. One conversation, two conversations, three conversations. You're not going to be an expert on mental health issues, but to just simply become aware that mental illness is real and that it is very treatable. That's what I would love for everyone to take away and pass along.
And for me,
Butler?
And for me, just the thing that there are resources out here, to add to what Mr. Butler said, but there are resources here. And I have some, I can share them with you, but we just have one just as new that was rolled out this weekend, 988. It's the National Suicide Prevention number. It's the National Suicide Prevention Lifeline number. It is free, it's confidential. We also have a couple of free lines that I can provide the information for, but that there are services out here that are free and that you can utilize, that if you're going through anything, you do have support, even if you don't have it in your home.
I'm gonna let Brother Sandino get the last one. I'm gonna go ahead and jump here. With the number one thing I actually really promote is that we need more persons of color and persons who are culturally competent and culturally sensitive in this field. And that's at all levels in terms of teaching, research, and practice. And so what I actually would encourage everybody to do, get your family, get those young people coming up, get them to think about being, in essence, a healer, a practitioner, a scientist in this field, because we need more people who understand the impact of culture and the intersection of mental health and how those things affect folks. So I want people to go to school to be clinicians. I want people to go to school to do this research so we can better understand all of the things we've talked about. So if that would be my takeaway.
Thank you. For me, I think I would like to kind of speak to the clinicians in a group or any clinicians that's joining us, is really just to check in and really have an honest conversation and evaluation of your own biases, your own struggles in whatever area you got going on, to have a conversation and owning that. Truth is that we all have biases. We just don't want to say it. And so just to have that honest conversation and not be afraid of educating yourself, stretching yourself. If you feel uncomfortable with a certain race or ethnic group, ask questions, listen. Don't act like you know if you don't know. Be honest. I mean, we're encouraging them to do that, and I think we can do the same and not really react on the encapsulated version of our experience.
Well, I want to thank each of you for your participation today. I think we have learned a lot, and the key takeaways that you gave to each of us, I think, are very valuable in thinking about not only accountability, cultural sensitivity, collective community and consciousness, but also like inner reflexivity, right? And thinking about, just as Dr. Sandino said, our own biases and things that we may be bringing to the table that might be inhibiting our getting services or others getting services. So thank you so much. I know you hear the thunder rumbling in the background, and I'm so sorry about that, but I am going to turn it over back over to Ms. Ussery, and thank you so much for being with us tonight.
Yes, hello. Thank you so much. Thank you, Dr. Bryant, Dr. Jefferson, Dr. Turner, Ms. Butler, and Mr. Sandino. This was really an impactful conversation, and I think everyone who participated really took something away from today's conversation. So thank you. Thank you for your responses and for being a part of this especially important panel discussion. As community gatekeepers and providers participating in this discussion, each of you has helped to enrich people, populations, and communities' awareness. So again, thank you very much. And happy birthday shout out to Dr. Bryant. Sorry it's raining like this, girl. Okay, so back to our PowerPoint. So we're gonna go ahead and go over those key takeaways once more, our mental health 4 facts. So again, mental health challenges can affect anyone and doesn't discriminate across race, gender, or socioeconomic class. However, minority communities can face additional challenges when accessing mental health care, as we've discussed during this webinar today. Next, mental health can affect our emotional, psychological, and social well-being. It can influence how we think, feel, and act, as well as help determine how we handle stress, relate to others, and make healthy choices. Examining our mental health is important at every stage of life, from childhood, adolescence, throughout adulthood. So when seeking assistance with mental health challenges, be sure to find healthy outlets and/or trained and compassionate individuals who are willing to offer support, whether it be during hurricane season, the seemingly never-ending COVID-19 pandemic, experiences of racism, or any emotional crisis. And last but not least, mental health is an important part of our overall health and well-being. Okay, so I want to thank all of our attendees for coming and listening to this discussion today. And I hope that you found something enriching and valuable that you can take back and add to your discussions with your families and within your communities. Please utilize the resources that we will be emailing to you after today's presentation. Once more, for those of you who may have Medicaid insurance, if your medical insurance coverage is from Medicaid, then you must make sure that your information is up to date. This includes your address. If you do not update your information, you may miss important letters from Medicaid, and you could lose your health insurance coverage. To update your information, you can visit the self-service portal at www.ldh.la.gov/MyMedicaid or call 1-888-342-6207. And that 988 number will also be included on our resource guide as well. So at this time, it is my duty. I will bring in our Deputy Director of the Bureau of Community Partnerships and Health Equity once more to close out our webinar. Mia.
Thank you so much, Ayana. Before we go, I'd like to thank the staff of the Bureau of Community Partnerships and Health Equity and the Office of Behavioral Health and the Bureau of Media and Communications for executing such a needed conversation today. Excuse me. A huge thanks goes to the entire Louisiana Department of Health team. And last but certainly not least, a special thank you to the Secretary of the Department of Health, Dr. Courtney N. Phillips, for her continued leadership in pursuing a healthier Louisiana. Please join us for our next conversation focusing on National Immunization Awareness Month on August 24th at 5 p.m. You can use the QR code on the screen to register, or you can also go to tinyurl.com/LDH-immunizeweb to register for our next webinar. This concludes our event. Once again, thank you everyone and good night.